gave them high-dose combination as the comparator drug. And so the AHEAD study was done, which did exactly that. Again, very difficult to manage patients who were exacerbation prone. They were treated this time with a higher dose of budesonide formoterol, 164.5 twice a day, and that is needed. And the comparator here was fluticasone salmeterol at the highest recommended dose, 550 twice a day. So 1,000 micrograms of fluticasone was the comparator in this trial. And this was a shorter study, just for 6 months, but each arm had over 1,000 patients. And once again, when you looked at the risk of severe exacerbations, the high-dose salmeterol fluticasone was very effective at reducing exacerbation risk. So the exacerbation risk is very low in this trial, but still, even here, there was a significant advantage to the use of the budesonide formoterol as maintenance and rescue. And this is also seen with hospitalizations or emergency treatments. Again, very few of these in both treatments. But once again, this approach was significantly better than the high-dose combination. This shows the percentage of days when as-needed rescue was used in both of the arms of the trial. And for about 60% of the days, no rescue is needed at all in either of the arms. This is 1, 2, 3, 4 as-needed inhalations, and very, very few patients in this 6 months of study needed rescue medication more than 4 times a day. And there was no difference in the two arms of the trial. So this approach does not mean that you're using a lot of additional rescue combination, but I think you're using it when you need it. Another advantage was because exacerbations were fewer, the steroid load was less. The number of courses of oral corticosteroids were fewer, and the total inhaled dose adjusted BDP equivalence, even with the rescue added, was 2,000 with the fluticasone salmeterol, 1,240 micrograms with the other approach. This is now a summary of all of the studies that have been done looking at this approach. I've shown you the STAY trial, and I've shown you the AHEAD trial, but this is every study that's been done looking at this approach. And every study shows benefit. Now, importantly, all of these studies have been supported by the sponsors who have this combination, AstraZeneca. These are all AstraZeneca-funded trials. But there are now 2 independent studies, one reported by Dr. Richard Beasley in the Lancet Respiratory Medicine, and the second by Alberto Papi just in this past month, which have confirmed these observations in randomized controlled trials. So we now have 2 non-industry sponsored studies that have compared this approach to standard high-dose combination and showing the same effect. And the reason this works, in my opinion, is that you are using rescue, which contains a steroid, early in the exacerbation. This is when patients are taking their rescue. Their symptoms are beginning. They're getting worse. They're beginning to wake at nighttime. They start to use a rescue inhaler. You're getting in with a steroid much earlier on than when the exacerbation has developed 5 or 6 days later, with inflammation fully developed. And that, to me, is the best explanation we can offer for why this approach is beneficial. In addition, we do not lose we do not increase the risk of poor control in these patients. This is an analysis by Eric Bateman of all of the Symbicort SMART studies, showing that overall control is about the same as any of the comparators, and the risk of exacerbations is fewer. Exacerbations is shown in the bottom slide. In these difficult patients, we cannot achieve perfect control no matter what we do. And that, in fact, is the is the topic I'll be discussing in my next presentation. A small advertisement for my next talk after the coffee break. So we cannot achieve overall control in all of these patients for sure, but we do reduce risk by taking this approach. Now, what about the therapeutic balance here? I've talked a lot about the efficacy, but what about the safety of this approach? And there are many concerns about the safety of using LABAs in this way. And they were highlighted. I just wanted to make the point I made yesterday. There is no pharmaceutical agent which is always effective and always safe. So we always have to think about this balance between efficacy and safety. And the safety of LABAs has really been a major issue, particularly in the United States, and particularly for the Food and Drug Administration in the United States. And that in part was because of this study reported in the American Journal of Medicine by Dr. Salpeter from Washington State, which suggested that the use of LABAs puts patients at risk of severe fatal events. And I want to highlight two things. The odds ratio is increased to 1.8 in patients for whom variable corticosteroids were used in clinical trials. What this means is that the steroids were not mandated. Patients could or could not be on steroids when entered into the studies. And the biggest study by far is a study called the SMART trial, but this is not Symbicort SMART. This is the United States SMART trial looking at the safety of fluticasone and salmeterol or salmeterol alone. And this accounts for 80% of all of the studies that Dr. Salpeter described. And that is the increased odds ratio. What is very puzzling in this analysis is that when steroids were mandated to be given, it wasn't a choice, they were part of the treatment with the LABA, she would argue that there is an increased risk of death, increased to 3.65. But if you look at the weighting, this accounts for about 20% of the entire studies reported here. And importantly, in this analysis, Dr. Salpeter elected not to include any study that did not have an asthma death. So all of the studies in which there were no deaths were not included. These are only the studies in which there was an asthma death, and the weighting was entirely driven by one trial, the US SMART trial, which is one of the worst designed studies in history of mankind, because it just sent salmeterol to patients by mail and followed them up by telephone. That was the way the trial was done. We have done a meta-analysis in Hamilton at McMaster University of every single study done, including the studies with and without mortality, both with fluticasone and with budesonide. And we got assistance of both GSK for all of the salmeterol studies and from AstraZeneca for all of the formoterol studies. And overall, when this analysis was reported by Roman Yeshka, who is a methodologist. He's not a respiratory physician, so he has no interest in whether this is positive or negative. But overall, we see this is the forest plot, no significant effect of adding a LABA to an inhaled steroid in these studies. Now, the FDA is very worried about these results, and for that reason, the budesonide formoterol SMART approach is not approved in the United States. It's the only country, I think, in the world where that is not approved. So they did an analysis, this is the FDA's own analysis, of the risks of LABA when with or without an ICS. Reported by Dr. McMahon a year and a half ago. And these are the different age ranges where studies have been done: 4 to 11, 12 to 17, 18 to 64, and greater than 65. Now, this is a a different way of showing data. I need to just spend a minute explaining what they have done. What they have shown here is the incidence rate, incidence difference per 1,000 patient years. So that number, 30.4, means there are 30.4 more fatal events per 1,000 patient years of treatment when the LABA was added compared to placebo. And so in young children, that is a very concerning number. 30, an increased risk of 30. In adolescents, it's 11. In adults, it's about 5. And in older patients, it's actually less, not quite significantly less, but less. And overall, the incident difference is 6. Which means 6 fatal events when a LABA is used compared to placebo per 1,000 patient years of treatment. However, when they looked at what they called concomitant ICS, now this is where in studies where ICS could or could not be added. The LABA was studied, sometimes with ICS, different inhalers were used, not in a single inhaler. This is what it looks like. Higher numbers in children. Now there's no significant difference, although there's a shift in adolescents. Again, a small shift, but not significant in adults.
no significativo desplazamiento en adultos y también en pacientes aún mayores. Y en general, la diferencia de incidencia es la misma.
By contrast, when they looked at studies
cuando observaron estudios donde los corticoides inhalatorios fueron entrados en el mismo inhalador para no poder tomar LABA sin consumir el corticoide, este es el aspecto de los resultados. Ahora incluso menores niveles en niños, no hay aumentos significativos en adolescentes con un leve cambio, no hay diferencia en adultos, y la única diferencia ahora se observaron en pacientes mayores de los 65 años, y estos fueron mayoritariamente pacientes con EP o C.
Y
en general, no había efecto en absoluto.
So the FDA's own data
Así que los datos propios de la FDA nos dicen que cuando colocan un corticoides inhalatorios y un LABA en un mismo inhalador sin poder tomar fármacos separadamente, no hay riesgo. Sin embargo, cuando los tienen en infusores independientes o permiten que los asmáticos sean tratados solo con LABA, hay un riesgo, y esto ha llevado al inicio de un estudio de seguridad de 60.000 pacientes, donde Chile también está participando, pero desde los Estados Unidos, para tratar de responder esta pregunta. Pero para mí ya se respondió a esta pregunta. Este gran estudio, yo creo, solo confirmará lo que la FDA ya sabe.
Just to finish and to try and be complete, when I'm talking about exacerbations, there are other approaches
otros abordajes que se han demostrado beneficiar pacientes con exacerbaciones.
These include mepolizumab, and I'll be showing you a lot of data in my next presentation on using anti-IL-5 approaches to treat eosinophilic airway disease with exacerbations. Omalizumab, I'll show you some data on that in the next presentation. Bronchial thermoplasty, which is an approach developed mainly by my colleague in Hamilton, Dr. Jerry Cox,
which has also been shown to reduce exacerbations. In one study, in pediatrics from Neil Johnson, again from Hamilton, Montelukast was shown to reduce exacerbation in children who had exacerbations when they returned to school. Cuando volvieron a las escuelas en nuestro otoño de septiembre en Hamilton, y finalmente tiotropium, mostraré estos datos en mi siguiente charla.
So I'm going to summarize by saying that I believe that asthma control can be achieved with almost all patients with asthma. And ICS are the mainstay of treatment, and for many patients, particularly those managed in primary care or
principalmente para los de cuidado intensivo o la oficina familiar, los esteroides inhalatorios por sí solos son suficientes. El gran problema que tenemos es estimular a los pacientes que se tomen los medicamentos. Esto es el gran desafío con los esteroides inhalados. La terapia de combinación con LABA mejoró
control
control
in
y
ICS.
reducir
There are some
exacerbaciones.
patients who do
Existen
benefit
algunos
from higher
pacientes
doses
que
of
sí se
ICS LABA, as I
benefician
showed you
de
in
mayores
the
dosis con
FACET study.
corticoides inhalatorios y
And
LABA
finally, the
a mayor
combination of
dosis.
ICS and a
Y la
rapid onset
combinación
LABA, this
de
is budesonide
LABA
and
y corticoides
formoterol, as
inhalatorios,
maintenance and
estos
rescue,
como
further reduces
mantención y terapia
exacerbation
de
risk
rescate,
in
reduce
exacerbation
aún
prone
más los
patients.
riesgos
Thank
de
you very much indeed
exacerbación
for your
en
attention.
pacientes con estas posibilidades. Muchas gracias por la presentación.